surgical therapy of male incontinence, and first is the ProAct, which was the first adjustable system available, and Flavio, like myself, and Erwin, who hopefully will show up as well, we were kind of the pioneers of this implant, and we still enjoy doing it. So Flavio, tell me what your current approach to ProAct is.
Okay, thank you, Dr. Hübner. I'm going to tell about the ProAct current indications. I have no disclosure, even though the Brazilians are very interested in balloons. As everybody knows, could you please stop? Don't move. Yeah, thank you. As everybody knows, the treatment during the first year, it was very well presented. It's a physical therapy treatment. And after the first year, we had some options like the slings, the balloons, and the artificial sphincter. I don't think anybody else uses the injectables, but it's very important to review the injections in order to understand the ProAct mechanism of action. So, there are many papers about injectables treating post-prostatectomy urinary incontinence. Most of them is with collagen, and they show results from 8 to 63%. And with time, people realize that injectables needs many new applications, that it doesn't work in many cases, and if you have a good region and without radiation therapy, you can get some good results in people with mild urinary incontinence. On the other hand, in some people, if you inject any substance in the sphincter, in the left sphincter, you can paralyze and increase the incontinence. So many people decided not to use the injectable, and mainly because if you use in everybody, you are going to double the costs of treatment. But the idea of injecting something to treat urinary incontinence still makes some sense. But if you had the ideal injectable needs to have no absorption, no migration, no allergy, a reasonable costs, and if you could modulate the amount of injectable without a new procedure, this also would be very nice. So, as they did in some cases for reflux, they try to create a balloon that would be the perfect injectable. So, the balloon would be a strong injectable without problems of absorption or migration. And it could be adjustable without any new surgical procedure. So this was the idea when they created the ProAct. The ProAct has some components. Here's the balloon. Here's the titanium part. Here is the guide wire. So everything helps you to put this in the correct position and to adjustable later on. This is the initial set of instruments. You have this dilator you could use to put in the correct position, and then you remove the trocar and put the balloon inside, and you could position the balloons in this correct position. Later on, they developed better instruments to dilate the region between the near to the bladder neck, and neutral cars, and you could easily put the balloon in the correct position. And this is the procedure. You do a cystoscopy, you put some contrast in the bladder, and then you put the trocar near the bladder neck. Here you see the bladder, here the systole. Then you remove the central part of the trocar, you put the dilator, create some space, and then you put the balloon here. After the procedure, you have two balloons, one in each side of the urethra, creating something like a little prostate that would compress the urethra. Here is the end of the surgery. You have here the ports, and you can put the ports in the subarctic space in the scrotum, and this would allow you to inject some more fluid and to adjust these balloons. This is an endoscopic view before and after the balloon's placement. You see it closes the urethra. Here contrast test. You see the bladder, you see the urethra, and you see the balloons working like a small prostate, obstructing partially the urethra in order to obtain the continence. We did some urodynamics in these patients, and what we saw, the bladder, and then there are some obstruction during the micturition, but the patient is able to empty the bladder and obtain continence in many cases. Here during the first year, you can, of course, in the office, just fill a little bit more liquid in the balloon. Of course, you have to go slowly, otherwise you change the balloon position and it loses the efficacy. Initially, we did a paper, a single center paper with 25 patients with severe incontinence, about 2 years of follow-up, and we have good results in 65% of the patients. 3 patients improved. We have no major complications in any of these patients, and the increased quality of life as well. Here, the average pads before and after the procedure, there was a significant reduction, and there was some increase in the Valsalva leak point pressure, showing the balloon was compressing and was creating some kind of sphincter mechanism. But we also had many adverse events. For example, de novo urgency, we have some migration of balloon, infection, erosion, bladder perforation, which was not a big problem. And our index of surgical revision was near 25%. After some more time, many balloons leaked, and then we had this, the patients return incontinence, and in the X-ray you could see this image. Here a patient with extrusion, which is common to many different treatments of incontinence. We also had this multicentric trial here in my group in Brazil, some centers in North America, in Austria, in New Zealand, and we could put together about 254 patients. And what we saw with 3 years follow-up, there was a group of dry and a group with significant improvement. There was an increase in quality of life. In terms of objectives, there was an increase in Valsalva leak point pressure in 46 patients who we did the urodynamics, and many patients required adjustments. Mean adjustment was about 3 adjustments per patient, which was not a very big problem because these adjustments could be made easily in the office. But we have significant adverse events. This balloon rupture was the thing that made many of us to leave the PROACT. It was acceptable during the first years, but after some more years, the number increased a lot. We had some fails in balloon position. This was related, for example, to early adjustments. You have to wait at least 1 month to start the adjustments. We have some cases of erosion that is similar to other methods. Pain, urinary retention, we had some perforations, and 22% of the patients, they need another procedure to treat incontinence. In conclusion, we say that PROACT represents an advance if comparable to injectables. It's minimally invasive, low pain procedure. It's reversible and adjustable, easy adjustable. There is no pump. This was another big problem. It was unpredictable. You see some patients that you put in the correct position, everything is fine, and then the device did not work. As we have new methods, for example, these links, I think they reduce the role of PROACT in treating urinary incontinence. I would say we still can offer this method to some patients, but I think few people are still using this method. This is my friend, Dr. Hubner, and our friendship continues even with this topic. Thank you.